Hi guys, Dr. Gillard. It is Thursday, it's week 8, and let's probably break this down into 2 pieces. We'll see how how things go here, and off we go. So let's talk about, this is a big one, small bowel obstruction. It's really not talked about that much, and it can be a life-threatening situation. And you can always tell how, because of my YouTube videos, this one has, I think, over 15,000 hits, which is really unexpected. So it shows me that this is a problem not well discussed or described. So what is it? Well, it's basically a beaver dam within the small bowel. And the small bowel, of course, is the small intestine, which of course is broken down into 3 pieces: the duodenum or duodenum, or duodenum, whichever, tomatoes, whichever you want, jejunum, and the ileum. And we know that's a tube where at first, the chyme from your stomach, the chewed up food, is secreted, and a lot of the nutrients are absorbed in the small bowel, including water and salt and things like that. But if you get a beaver dam, if you get some type of blockage in the lumen, you can get a beaver dam. You can get the fecal material stopped and it can't proceed downstream. Ultimately, it goes into the large intestines and into the rectum, of course, and you make a bowel movement and get rid of it. So it's officially when something blocks or limits the arboreal flow of intestinal content through the small bowel. You could see a question like that. Arboreal is downstream flow of intestinal material, fecal material, away from the mouth toward the anus. May cause severe abdominal pain. So as the backup, just like a beaver dam, as the backup occurs, the intestine stretches and stretches, and stretch receptors can fire, and it can cause horrible 10/ on a scale of 0 to 10. 10 is in the hospital. It can cause 10/10 pain, and it will send the patient to the emergency room. In fact, it accounts for about 15% of all acute abdomen emergency room visits. So if someone comes in the ER and they say, "Oh, my tummy's killing me, I can't stand it," 15% of the time it's from obstruction. Then we have appendicitis, could be another big chunk, and gallstones, things like that. So this is, when you have 10/10 abdominal pain, that is under the abdominal pain. 10/10 abdominal pain is under the category of acute abdomen. Acute abdomen. So let's talk briefly about acute abdomen. And that's 10/10 severe abdominal pain, often associated with nausea or even vomiting. And about 10% of all emergency room visits are because of acute abdominal pain or acute abdomen. And it can be life-threatening because it can be associated with peritonitis, which turns into septicemia, which kills you. The general causes of acute abdomen is when a viscera, what's a viscera? That's like the small bowel itself, like a piece of the intestine or the stomach or the pancreas or the appendix. That's a viscera. Those are structures inside the abdomen. When a viscera gets infected and inflamed and perforated, vascular occlusion usually occurs after the inflammation. Kind of put those out of order. And specific causes, I do like this slide, and I know it's a lot to memorize, but you got to know this. These are the causes of acute abdomen. Somebody has 10/10 pain, these are the things it could be. It could be an inflammation of the appendix. It could be an ulcer that's perforated or near perforated. It could be acute pancreatitis, diverticulitis, ovarian torsion, ectopic pregnancy, where a fallopian tube is ruptured by the growing embryo. Acute peritonitis, intestinal obstruction is which we're talking about now. A volvulus or intussusception are 2 specific types of intestinal obstruction we'll look at. Could be a ruptured abdominal aortic aneurysm. It could be a lacerated liver or spleen. That would be after a car accident. Ischemic bowel from maybe let's say someone has atrial fib and they have an arterial clot and it goes and gets stuck in the superior mesenteric artery, and there goes all the blood supply to intestine and it dies. So that's ischemic bowel. Cholecystitis is a stone stuck in somewhere in the gallbladder or in somewhere in the biliary system that causes severe pain. And urolithiasis is when a stone gets stuck in the ureter. All right, back to intestinal obstruction. So there's two main causes. There is mechanical, which is by far the most common, and that's when something physically blocks the flow of bowel movement, of the flow of fecal material through the lumen. And it could be from a tumor inside the lumen or a tumor inside the wall of the intestine that pushes into the lumen, or a tumor on the outside that is near the intestine and it pushes and squishes the intestine in. So there's three ways that can happen. And then there's functional. This is usually a problem after surgery. This is when none of the intestine, the small or large bowel, work. Peristalsis stops. We're not going to talk about that one too much, but we are going to talk about these mechanical obstructions quite a bit. We're going to go into the weeds on these. Not crazy into the weeds, but so here's a good picture where we had a beaver dam occur right here for whatever reason. Let's say they have intestinal cancer, and the cancerous tumor has grown so big it acts as a blockage or a beaver dam, and the fecal material normally is going that way, and now it can't get through. So now fecal material has backed up. If we could see through this piece of intestines, this is all fecal material. But remember, the fecal material is dirty. It's filled with bacteria, and normally those bacteria they don't stay around that long in the intestine because peristalsis pushes them along. But if they get blocked, they have time to do what bacteria do, and that's they breed like bunny rabbits. And the as more and more and more bacteria occur, they invade the wall and inflame the wall of the intestine, and they release gas, like methane gas and different types of gases, and it literally blows the intestine up like this, and that can cause incredible pain. So that's small bowel obstruction. And what are some of the general causes? By far the most common is something called adhesions, which we will talk about in a little while. And in adults anyway, that's by far the most common cause. 75% of mechanical small bowel obstruction is caused by these adhesions. It's scar tissue that occurs inside the peritoneal cavity, usually after surgery or something, or it doesn't have to be. Intestinal hernias, so where the intestine goes through a hole, like an indirect inguinal hernia, or it goes through the umbilicus, it goes through the umbilical plate, or like a Spigelian hernia, where it goes through the linea semilunaris, the tendon on the outside of rectus abdominis, a hole in the abdominal wall, and they get pinched. And if the intestine goes through a hole and gets pinched, it's just like a blockage. You can't move fecal material through there. Carcinomas that occur inside the lumen or occur in the wall or even adjacent to the intestine, another 10%. And then we have these other causes. So let's take a look at these other causes. So intussusception and volvulus. Intussusception is actually the most common cause of small bowel blockage in children. Intussusception, we'll take a look at that. And volvulus is pretty close as well, but it's not as common as intussusception. It's where the proximal or the upstream, let's see if I can draw it since I have my tools. So here's the intestine running along, and here's the normal upstream part of it. And what happens is you get a piece of scar tissue. Whoops. What happened to my drawing there? I think I just discovered if I hit the E button, I've been using this program in a long time. Oh wow, E for erase. That's good to know. Anyway, now I have to redraw it. But we have There's our downstream piece of intestine. And then here's our upstream piece of intestine. And normally fecal material is moving this way in our little cartoon here. And an intussusception occurs, I'll draw it in red, when you get some scar tissue. It doesn't have to be scar tissue, but oftentimes you get something that kind of sticks to the intestine and acts as an anchoring point. And then we have peristalsis going on. So what happens is this piece of intestine starts to go down inside this piece of intestine. And it's still open, but you could see it would be. So this is the kind of the new look. So this intestine has ferreted into this intestine. And that's what an intussusception is. I can hit my, let's see, erase tool. Hey, I learned a trick. Oh, but I still can't advance the slides. I still got to hit escape. All right, so here's a better drawing. It loves to occur right at this ileocecal valve. And this can act as kind of the sticking point. That's called the lead point. The lead point where the intussusception occurs. And because of peristalsis, the distal ileum has actually worked its way inside of the ascending colon. So that's not good. Something called the Meckel's diverticulum. I don't think we talked about that. I think I had to cut that out of slides, but in embryology. But Meckel's diverticulum can do this as well. Act as a lead point. Now a volvulus is a tangled mess. So you have a piece of scar tissue kind of wrapping up the intestine. And because of peristalsis, you start to get a twisting of the intestine on itself. And if you're fecal material, you can see you can't get through here, can you? It's really hard. So this acts as a beaver dam right here. So another cause of small bowel obstruction. Strictures are not tumors in the lumen, but you can get scar tissue building up in the lumen. So the lumen gets smaller and smaller and smaller. And Crohn's disease is a classic example of that. It's an inflammatory disease. And again, if we draw here's our piece of small bowel here. And it keeps getting hit with inflammation after inflammation. You start getting scar tissue from the inflammation building up. And over time, that acts as a beaver dam, and food has trouble getting through there as well. Right? Radiation for cancer can do that as well. Something called gallstone ileus is another interesting phenomenon, where the gallbladder touches a piece of the small bowel, and an inflammation, maybe they rub together and it starts causing an inflammation, and the inflammation gets so bad that a hole develops between the gallbladder and small bowel. And or you could have cholecystitis. You have the gallbladder becomes inflamed because of gallstones stuck in the neck of the bladder, and therefore you already have an inflammation going on, and then the intestine touches it, and the inflammation spreads into the intestines, and you get a hole between the intestines and the gallbladder. And therefore the stones that have formed in the gallbladder can actually dump into the intestine, and they get stuck down at the ileocecal valve. And that's called gallstone ileus. And here's an example of a patient with gallstone ileus. And this is an A to P view. You guys are fairly good at looking at radiographs, so you can see the iliac crusts down here to get an idea of where you are. But here is the gallbladder. Here's the liver. The border of the liver is here. And you should never ever see gas in this area. Like, that's gas with inside the gallbladder. And the only way that can happen is if there is a fistula between the gallbladder and the small bowel. And what happened here is the stones dumped out into the small bowel, and they came to the ileocecal valve. Let's draw the cecum. We could draw the cecum right here, and the ascending intestine would be here. And then there's the ileocecal valve would be, I kind of drew it off a little. But the gallstones start piling up right in here because they can't get through the ileocecal valve, and now we have ourselves a beaver dam. And you can actually see the haustrations of the small bowel, the haustra, are these little sections, and you can see if the patient is supine when you x-ray them. You get this classic stack of coin appearance. And furthermore, we don't see any gas in the ascending or the transverse colon or the descending colon. This is all small bowel gas patterns. So there's nothing getting through, not even gas. So you have an absence of gas, normal gas patterns in the colon, and then you have too much gas. It can get really bad where the whole stomach blows way up, which hasn't happened yet. But all right, what about other causes? Well, we said things external to the intestine to push in, so adjacent tumors or abscesses or hematoma or a lymph node, celiac lymph node that's really swollen up, probably filled with cancer. It can push into the intestine and cause obstruction. People swallow crazy things, and you'll learn about that probably when you get to psychology, but people like to swallow things, and here's someone who swallowed some ball bearings. And surprisingly, they made it through the ileocecal valve, but because of gravity, they can't get up the ascending colon. And yeah, this is a small, not super small child, but this is, you can see the growth plates. Looks like growth plates here. But anyway, so there's ball bearings, and it's acting as a beaver dam, so they're not getting fecal material passing through here, so they have small bowel obstruction because of these foreign objects. And of course, you can have different degrees of different severities of blockage. Partial blockage, where you get some distal passage of fecal material and water and salt and things like that. Or you can have complete blockage where nothing gets passed. Of course, complete blockage is much more dangerous. You'll be in the ER very quickly with this problem. If it's partial blockage, you could have upset stomach for months and months and months until you figure it out. You start losing weight because nutrients aren't getting past the blockage. What about the pathophysiology of ischemia and a perforation? Well, I kind of drew this when we first started, but with regard to pain, the stretching of the walls is what causes the pain and the inflammation within the walls. There's nociceptors within the intestinal walls. But the stretching, because of gas buildup mainly, can start to crush the blood vessels in the walls of the intestine. And now, without blood flowing properly through the intestinal wall, it becomes ischemic, and that causes horrible pain. And if nothing's done, it becomes necrotic and gangrenous and can rupture. And if you eat a hole in the wall, as the bacteria build up, the pus and the byproducts of inflammation and the bacteria can flow out into the peritoneal cavity, and you got yourself peritonitis, which can go into septicemia really quick, and it can kill you. Just some anatomy. Remember what the intestinal wall looks like. We have blood vessels here in the lamina propria. Remember, this is the mucosal layer, has those three layers. And you can see there's lots of blood vessels and lymph vessels in the lamina propria. But now if we get some fecal material stuck, you can see now, because the fecal material, the bacteria in here have invaded the walls and caused a wicked inflammation. And that's not good. And with time, you can actually rip a hole through the intestinal wall, and now we have all the pus and stuff leaking out into the peritoneal cavity. Right, so here's this was a inguinal hernia where a piece of bowel got strangulated. All the blood vessel, the same thing happened right here. Only it wasn't, well, there's fecal material in there as well, but it got stuck in the inguinal canal, which we will talk about. But you can see we have a piece of dead bowel right here. It's purple and blue, and this whole section of bowel will have to be cut out. What are the clinical signs? There's a lot of clinical signs. This is a hard diagnosis to make because there's so many different presentations and clinical signs. But the stretch can produce 10-10 pain, so they'll come in with acute abdomen. and just the bacteria that invade the wall will spark an inflammation, and that can set off nociceptors as well. Big clinical sign is dehydration in this, but there's so many other things that can cause dehydration, but the patients typically present to the ER with dehydration. Well, how does that work? Well, if the blockage occurs way up in the duodenum or even in the jejunum, anything downstream, there's no water, there's no fecal material, there's nothing, no nutrients, there's nothing going downstream. And we know that the intestines are super important for reabsorbing water. And therefore you won't, and salt for that matter. So salt and water will not be reabsorbed, and you're going to get yourself a wicked dehydration because of that, and chloride as well. And that's going to spark hypotension and hyponatremia. We'll get to those. I probably should have cut those out for right now. And then on top of that, these patients are throwing up. So they're throwing up water and salt, and sodium and potassium is all being vomited out. So you lose more salt and water, and now you're losing potassium and hydrogen ion. And so now you can imagine what the picture, the blood work is going to look like. So therefore the dehydration plus the emesis result in low blood volume because you don't have enough water, which causes hypotension, and then hyponatremia and hypokalemia, and then metabolic alkalosis because you're vomiting out hydrogen ion. And to make things even worse, the hypotension activates the R2A system. And we know that's going to stimulate the release of aldosterone. And aldosterone is going to try to reabsorb a little water, but it's going to kick hydrogen ion and potassium out into the filtrate of the nephron. So you're going to lose more potassium and hydrogen ion, which is going to worsen the metabolic alkalosis and the hypokalemia. Body does not tolerate potassium imbalances or hydrogen ion imbalances well at all. So you can be very, very sick. Malnutrition, I said, probably more with a partial obstruction where you're still not, you don't have to go right into the ER. You're still getting some water flowing downstream, but a lot of your calories aren't getting through because of the blockage. The bacteria are eating all your food. Eminence, we said throwing up, but it could be so bad that you throw up a green bile. So that could be the first sign, in fact, of obstruction. And if you have, let's say, in the distal duodenum, if the blockage is there, the normal bile that's released, and from inflammation and stress you can release bile as well, it backs up and is pushing against the pyloric sphincter, and it can start to leak into the stomach. And the stomach does not like bile, and it's very nauseating, and it'll cause a reflex vomiting, and you'll be vomiting up green bile. That's a sign, that's good sign that you have some type of intestinal obstruction. There's a newborn, mom woke up in the morning, the baby is throwing up all this bile because the baby had obstruction from a volvulus or from intussusception. Colicky abdominal pain, that's another, because we talked about 10-10 pain, but they also present, they often present with a colicky pain, especially at first. And that means that when the blockage first occurs and peristalsis fails to push the fecal material downstream, almost like a secondary peristalsis in the esophagus, another wave of peristalsis will hit just a little bit upstream to the blockage and try to push it through the blockage again. And it'll get harder. It'll happen again, and the peristalsis will push harder, stronger contraction, and it'll happen again stronger. And you get this progressive, each one of these peristaltic waves will cause pain, and the pain will get worse and worse and worse until the phenomenon finally burns out after an hour or two. But that's a colicky pain where you get crescendo, decrescendo, that's music. Like you want, when crescendo means the music will ramp up very strong, and decrescendo, the music goes down to a very low level. That's crescendo. So the pain can ramp up very strong, and then it can slowly back off. All right, some other clinical signs. So if you have a complete obstruction and no fecal materials getting through, you're not going to have any bowel movement. So no fecal material coming out is called obstipation. If you have less than 3 bowel movements a week, then you have constipation. That's probably from a partial obstruction. Could indicate constipation. Obstipation means basically no bowel movements. Or they say you can have 1 bowel movement a week, but it's so hard. It's so hard you have to actually go put your fingers inside your anus, inside your rectum, and pick it out and pull it out. It's impacted. It's so hard that has to happen. Other clinical signs, so tachycardia, that's from the hypotension. Hematochezia is a really bad sign. If you start having red blood come out, that means that you're bleeding. That means you've perforated into the intestinal wall and tapped into some blood vessels, and the blood is leaking into the intestine. That's a bad sign. Distended abdomen, so you're going to get the abdomen all filled up with gas because of all the bacteria, the new bacteria that are popping up produce gas, so you get extension. Auscultation, so we've talked about this in lab, about auscultatory sounds. When you first have a small bowel blockage, you'll have hyperactive bowel sounds. More than 40 clicks and gurgles will be heard. Later in the obstruction process, the peristalsis gives up, and you'll have no bowel sounds later in the process. When you percuss the abdomen, it'll be hypertympanic. We said when you percuss the abdomen, normally you have, it's mostly tympanic, but there's some, because of the fecal material, there's some dullness as well. But this abdomen will clearly be bloated and sound like a drum. You're percussing a drum. Deep palpation, when you get over the area of blockage, it'll be extremely painful. They may have involuntary muscle guarding to protect you from pushing into it because they know it's going to hurt. They've already been poking around and they know it hurts there, so they either voluntarily guard the muscle spasm, or in the later stages it's involuntary. That indicates peritonitis has probably started. But deep palpation over the lesion will be very, very painful. And when you deep palpate into the adjacent quadrants, it may not be painful unless you do a rebound test, and that can make the original area painful. I think I have a slide. So let's look at the signs of peritonitis, and we've talked about these in lab, but the abdominal quadrant tenderness with percussion and palpation indicate peritonitis. There's a cough test, like a Valsalva's test in a way, only you have the patient cough really hard, and if he or she winces in pain when they cough, that's a positive cough test. It's a sign of peritonitis. Muscle guarding and rigidity, I think I have a slide on that, but that's an indication as well. We'll look at some stats on that in a minute. And then rebound tenderness. If they have pain, let's say it's in their left lower quadrant, when you did deep palpation and you pushed down in the left lower quadrant, oh, they had horrible pain and they cursed at you. If you go into the right lower quadrant and sink your fingers down, it doesn't hurt them. But if you suddenly snap your fingers out of there, which is a rebound tenderness test, so doing rebound tenderness in the left lower quadrant, if it reproduces the right lower quadrant pain, the patient, that's a positive sign that peritonitis has developed in that region. All right, and that's everything I just said about rebound tenderness. So, and you can do that if you did deep palpation, they really didn't have much pain, maybe a little bit in the left lower quadrant, you could do rebound tenderness right over the left lower quadrant and see if that exacerbates it. So that can also be a sign, but it's and if a positive, when you do rebound tenderness in the adjacent quadrant and it recreates pain in the same quadrant that you found deep palpation to be painful, that's a pretty good sign for early peritonitis. They need to be referred immediately to the emergency room. We said this in lab, how many experts discourage rebound tenderness anymore because it's cruel and unusual. Because we can figure this out with other tools, but nevertheless you could still be tested on it. So this patient has pain in the left lower quadrant upon deep palpation, and to see, just to kind of see if there's peritonitis, you can push into the right lower quadrant and then unexpectedly withdraw your hands quickly, and if they have pain, out should be in the left lower quadrant. That's a positive rebound test. Probably indicates peritonitis. So guarding, again, we've explained this in lab, but guarding is a voluntary contraction of the abdomen, so the patient is trying to protect themselves from you poking them. And rigidity is involuntary guarding, a muscle contraction of the abdominal muscle wall, of the abdominal muscles, because peritonitis probably started. And the presence of guarding doubles, and the presence of rigidity quadruples the likelihood of peritonitis. So they're very strong indications of peritonitis, which is, you immediately refer them to the ER. Other common causes of guarding and rigidity: appendicitis is very common, another emergency room favorite. Cholecystitis, another emergency room favorite. And perforated bowel is from the intestinal obstruction. Okay, what about lab findings? And remember, we're still talking about mechanical small bowel obstruction. So they're going to show signs of dehydration. All right, we've already explained how downstream doesn't get salt and water reabsorption by the intestines, and therefore you become dehydrated. And plus the emesis, the throwing up, you're going to lose hydrogen ion and potassium, so you have hypokalemia and alkalosis as well. Right, so there's the alkalosis, everything we talked about, and hypokalemia, everything we talked about. So if a big infection occurs, you're going to start to get an elevated white blood cell count, maybe even a fever as well. I could have added fever in there. So those are other, but fever is not a lab finding. So elevated white blood cells. Radiographic finding, we already talked about that. So stack of coin appearance because of the bacteria buildup and the release of gas. And then a downstream paucity of colorectal gas. So you're not going to have any gas in the colon or wherever the blockage occurs. The downstream gas is cut off. You might see gas in the abdominal cavity outside of the intestine. That's very bad. That's a sign of inflammation. And here's another picture of a nice stack of coin appearance. But again, all of a sudden, where's all the distal ileal gas? Should be right in here. There's nothing. So we can tell the blockage is probably up in the proximal ileum or distal jejunum. I would guess it's probably right about here is where the beaver dam is, because there's nothing. There's nothing down here, and there's nothing up the ascending colon. There's nothing across the transverse colon. Remember, those are big pipes, so you see big gas. Nothing in the descending colon or sigmoid colon, and a little bit down here in the rectum, but yeah, so there's just not a lot of gas there. Classic small bowel obstruction. There's some more gas in the appendix from a gallstone ileus, which we've already talked about. All right, functional obstruction. I'm not going to say too much about it. Functional obstruction is caused mainly by something called ileus, or paralytic ileus, or adynamic ileus. Merck Manual uses adynamic ileus. Merck Manual is also a board book. So you need to know all those terms. So it can mimic bowel obstruction, but there's no obstruction. So in ileus, as one of these AKAs gives it away, paralytic ileus, the small bowel, or the entire bowel, small bowel and large bowel are paralyzed. They're not working. So peristalsis has completely stopped or been arrested, is the fancy medical word for that. Peristalsis is arrested. And therefore, all your fecal material is frozen and not moving anywhere. So your bacteria are running wild, and that's, in a sense, an obstruction. Specifically, it's a functional obstruction because we can't see any mechanical cause of it. So the number one cause of this by far is after surgery. In fact, it's almost expected. It takes a couple hours for your bowel sounds to come back after a operation in the abdomen for any reason. And we're not exactly sure what the mechanism of that is. But in about 1.5% of abdominal surgeries, and even spine surgery, right, like the Tiger Woods surgery. Well, I guess he had another surgery. I guess he had another one now for his car accident. But for the original, very successful anterior lumbar interbody fusion, they have to go in through your abdominal cavity usually. And so one of the complications arising from any abdominal surgery is the ileum doesn't turn back on, and that can be a disaster. But eventually it gets started usually. Hypokalemia, which is one of the complications of mechanical small bowel obstruction, can actually stimulate ileus. So some people with small bowel obstruction can end up having complete bowel obstruction from paralytic ileus because of the hypokalemia. Hypokalemia is the most common metabolic cause of ileus. All right, what are some other causes? Drugs, tricyclic antidepressants, opioids, and histamines. For chronic pain, it's very common to prescribe tricyclic antidepressants in combination with opioids. Not so much anymore. The opioids are pretty much, everybody's scared to death to prescribe them nowadays. The pendulum has swung too far. But this is a bad combination. Antihistamines, tricyclic antidepressants, and opioids can induce ileus in people. Peritonitis can induce ileus. Abdominal aortic aneurysm, which bleeds, and we don't exactly understand the mechanism of that, but it does. Blood touching the outside of the intestine causes it to freak out and stop producing or stop peristalsis. It could also, the bleeding can also induce a hypovolemia, which turns on the R2A system, which induces hypokalemia. Right, so now look at the difference between small bowel obstruction. We've seen a couple of those, right? And now look at this ileus, and you can see when everything stops, the bacteria run wild everywhere. And now we have the transverse colon filled with gas, the ascending colon, descending colon. So this is ileus. This was a patient who was on tricyclic antidepressants and Percocet for a long time from a failed back surgery. And they got in the hospital for acute abdomen, and here's what the x-ray showed. So they ended up having ileus. Functional obstruction versus ileus, clinical signs. So, well, dehydration can come on really, really quickly in functional obstruction or ileus because none of your intestines are absorbing water. And so you can become dehydrated really fast, much quicker than with mechanical small bowel obstruction. And then the other signs are really the same as small bowel, so I won't go through them again, with the exception of perforation is less likely because in a small bowel, mechanical small bowel obstruction, you have an isolated area that is packed with bacteria, and the inflammation can eat a hole in the intestinal wall quickly. But with ileus, it's spread out over the entire intestine, so the bacteria aren't so concentrated in one spot, so you're not going to get perforation as quick. So differential diagnosis for small bowel obstruction, mesenteric artery ischemia. Kind of talked about it. So if you get a beaver dam, if you get a blood clot or something pinching the superior mesenteric artery or inferior mesenteric artery, the intestine can start to die, right? Become ischemic, and that will cause 10-10 pain, and that's one of the causes of acute abdomen. It's a rare cause, but it can happen. Patients with AFib, I already gave that example. The artery can get into remember this? There's the superior mesenteric artery right here. There's a celiac trunk, and the next big branch off is the superior mesenteric, and look at all these branches. These are all the intestinal. We have the jejunal branches and the iliac branches here. It even goes to the ascending colon, colonic branches here. And can you imagine getting a big blood clot stuck right here. And then basically all this intestine is going to become ischemic, and you're going to have horrible, horrible pain. So another differential diagnosis, let's see, we got ischemia and colonic obstruction. So maybe you have a tumor growing colon cancer and you get a beaver dam going down there. So that could be another differential diagnosis. Pretty hard to tell the two apart. Maybe if it's way down in the colon, you're probably going to reabsorb water and such. So you probably won't have the dehydration signs with colonic obstruction. I could have added that in there. Maybe I'll put that in there if I can remember slide 55. What do you do for treatment for these things in the ER? Well, you're dehydrated, so they treat that first of all. So they give you fluid and with electrolytes. Fluid resuscitation. You don't obviously eat anything because you don't want to add to the beaver dam. And then you just wait and see what happens. If you don't get better every 4 to 6 hours, and of course you do a CT and ultrasound to see if you can find out where the obstruction is, or do abdominal exams to see maybe it's a hernia, an umbilical hernia, or see what the problem is. But basically you're in the ER for a long time, just waiting to see if maybe the obstruction will pass and the bowel will get through and start working, and it will get through the blockage. If you don't, you have to surgically remove that. You'll undergo laparoscopy, and they'll cut out the bad intestine and sew the good ends together, and that's it. And hope you don't get adhesions from surgery. If it's an incarcerated hernia, you can try to push it back in yourself. You guys should never do this. You'll send them to the emergency room, but they can try to reduce the hernia themselves. Here is another bowel that was strangulated, and you can see it's all gangrenous. There's no way this would have fixed itself, so surgeons will have to basically cut the intestine here, and get rid of all this, and sew those two ends together. Okay, simple as that. Hang on here 1 second. Take a little water. All right, everybody understanding this? All right. By the way, this is why if you have 10-10 pain, you don't take painkillers at home or do moonshine shots or something like that. The pain is there for a reason, to get you to the ER. The mortality with this scenario with gangrene is about 30% if you delay the operation for more than 36 hours. So you have to be very careful. What is the prognosis? It's very low. There's about an 8% mortality for strangulated obstructions, which is, it's low, but that's still kind of high, actually, I think. But 8 out of 100 will die from that, especially if the surgery is performed outside of that 36-hour mark. The septicemia is usually what kills people. If there's a delay, a big delay, like a week delay, and you can't get into a hospital, it's much higher mortality rate. For non-strangulated, though, small bowel obstructions, it's a very low. You can get away. It's the strangulated where ischemia and gangrene sets in, because that almost always leads to peritonitis. All right, let's do adhesions. I think I wanted to stop here, but let's go a little. I have some energy still. So adhesions are the most common cause of small bowel obstruction in adults. They're the culprit in about 75% of the cases. Remember, we drew a picture of the adhesions on the intussusception, just showing what they look like. So we should talk about adhesions. So it's just thin bands of scar tissue that forms inside the intraperitoneal cavity, inside the abdominal cavity, and they're sticky. They can stick to intestines, and they can tangle up intestines when peristalsis occurs. Remember, the intestines are freely movable because they move quite a bit when peristalsis, when they're pushing fecal material. They can move a lot, and they can get tangled up in these adhesions. And that tangling can lead to a small bowel obstruction. Here's an intersurgical picture where you can see a nice thick band of an adhesion here that's stuck to two small bowel together here. And they're just in the process of cutting that out. And where do the adhesions attach to? They are attached between adjacent intestines, so the intestines could be stuck together from this. They could stick the intestine to the abdominal wall, and where the old surgical wound was, they can also stick the intestine to the surgical wound, kind of from the inside out. Okay, and they can become quite painful. Here's a nice cartoon of an adhesion strangling this loop of bowel here to the point it's become ischemic and starting to get a little gangrenous. So that's not a good thing. And you can't push, as this intestine swells, you can't push fecal material through there. So you can get a small bowel obstruction from that. Here's another intraoperative picture showing the adhesion quite nicely between these two pieces of bowel in the patient with chronic belly pain. So people can usually have these and they're completely asymptomatic. About 12% of the cases, the adhesion can cause ischemia, which is big trouble, right? That'll be acute abdomen, you'll be in the hospital. And about 3% of adhesions eventually are going to require surgery to remove that obstruction and remove the adhesion which causes the obstruction. If the adhesion is just hanging out and not really wrapped up in intestines, it's thought that they're not going to cause any trouble. It's just when they stick to intestines, and because the intestines have the ability, the adhesions don't have any pain fibers in them in and of themselves, but when they wrap up intestines, that's when it can get painful. Where do they come from? So peritoneal cavity insult, classics, status post-surgical procedures. Like if you've had, I've known students who've had adhesions following appendectomy or cholecystectomy. And you can have congenital adhesions as well, like a persistent Vitalin duct, which I don't think we usually get to that. I have YouTube videos on it, but that's considered a congenital adhesion. But most of the time are acquired adhesions, and it's almost always from some type of surgery, or if you get stabbed by a knife or a bullet or something like that. Anytime you cut through the peritoneal cavity, it heals, and the healing can go kind of crazy. So what is it about surgery or any type of peritoneal injury that causes them? What's the physical damage that triggers them? And other things that can trigger them through experimentation: exposure to intestinal contents. So if you're doing surgery and cutting out a bad piece of intestine, some of the intestinal juice gets out. That's been proven to cause these things. Exposure to intraoperative substances like the dust on operative gloves, the gauze on surgical gauze for soaking up blood, the sutures, overheating by surgical lamps, irrigation fluid. There's been a lot of experimentation that's demonstrated these are causes, so surgeons have to be careful about that. And then there's a genetic propensity. Some people just have a tendency to make scar tissue, and so you can have genetics as well. What about the timing? So it's kind of the 1 year rule. So after you've had your appendectomy, or you've been stabbed by a sword or whatever, after your peritoneum's been cut and stitched up, if they're going to show up and be troublesome, it's usually within 1 year of the surgery. It's not true for every case, but usually that first year is the risk period. All right, let's get into hernias now. Let's see how far we can go on this. So small bowel hernias in general. There's a Spigelian hernia right there. And the limia semilunaris, remember that one? So small bowel hernias, that occurs when the small bowel hernias through some type of defect in the abdominal wall. Like it loves to go where tendons are, like the linea semilunaris. Remember the linea alba, which runs like this. Remember that from Gross 2? Then we have those tendinous intersections that give you the washboard. Hernias can pop up between these things. They can definitely pop up through the umbilicus and then down in the inguinal region. There's several. We have a direct and indirect inguinal hernia we can talk about. But that's what it is. It occurs when small bowel herniates out through the belly button or through these things. And the small bowel, I mean, it's just like a small bowel obstruction, right? It can get pinched, and you can't get fecal material passing through anymore. You can also get hernias in the lesser sac or the retroperitoneal space. They don't happen as often. We'll take a look at those. These small bowel hernias account for about 10% of mechanical small bowel hernias. They account for about 30% of small bowel surgeries. And the trouble with small bowel hernias, because they get through a little tiny hole in the abdominal wall or the inguinal canal, it's a tight squeeze, and so it's 100% blockage, and therefore they can become, that's said to be incarcerated when they're completely blocked, and plus they can get stuck when they go through the hole. That's called incarceration. I have a picture of that in a minute. And that's going to almost always lead to death of the tissue, gangrene, and a need for surgery. Some terminology of hernias. So an orifice or a defect or a hole is the hole in the abdominal wall where the intestine pushes through, or it might be through the deep inguinal ring, which into the inguinal canal. That's another orifice, the deep inguinal ring, or the rip in the abdominal musculature in the abdominal wall is an orifice. The hernia sac is all the stuff that goes through the orifice. I'll show you a picture here in a second. So here's a picture. So this looks like the umbilicus, and we have a piece of intestine has ripped through the umbilical plate, and now we have the intestine doing a loop out here. And we have a small bowel obstruction because there's a beaver dam right here. We can't get fecal material in here. Right? Maybe a little bit of water might be flowing through here, but for the most part, we're getting a huge buildup of fecal material here. The orifice is this hole or this defect. In this case, it's the umbilical plate. The hernia sac is all the stuff on the outside, and notice that the hernia sac takes all the peritoneum with it. So the parietal peritoneum is in purple here. Right? That's the outer cover. That's the peritoneum, basically. That's the peritoneal membrane. That's in purple. And then we have the visceral peritoneum around the intestine in the space in the middle. I mean, this is peritoneal cavity here. Any place between intestines is part of the peritoneal cavity. But peritoneal cavity is between the parietal and the visceral peritoneum. But so you can see that we have different members of the hernia sac, and we have some skin here, and we don't have any muscle here, but the hernia sac can be different layers depending on what type of hernia it is. And remember the layers of the abdominal wall. So we have skin, which is epidermis and dermis for chiropractors. For medical doctors, medical students, they include subcutaneous tissue. It all depends on what board book you use for a definition of, quote, skin. Then we have the muscle and the aponeurosa of the muscles, the next layer down. Then we have the deep fascia, which is the transversalis fascia, extraperitoneal fascia, sometimes called preperitoneal fat, is how I learned it, and the parietal peritoneum. Then greater omentum, then visceral peritoneum, which is wrapped around the intestine, and then the intestinal wall itself. Okay, there's a nice picture. I've thrown that on a test now and then just to see if you can remember all your anatomy, what you learned in Gross 2. I won't go over this because I just went over it. But remember, the deep kind of peritoneums, or the deep layers of fascia starts here. There's that rectus abdominis muscle. Remember, it's enclosed by a rectus sheath. There's an anterior fibers of the rectus sheath, the posterior fibers of the rectus sheath, and those have those 3 layers going down there. I'm not going to go over that, though. You guys should know that. Okay, but I'm not going to, should have probably taken that out because I'm trying to get away from doing anatomy. So general types of hernias. So we have an external hernia, means the hernia sac is protruding through the anterior wall defect. These external hernias are by far the most common. You can see them, you can feel them. But there are another type called internal hernias, which you can't see. So these occur within the abdominal cavity, specifically a place, remember the foramen of Winslow, which connects the lesser sac to the greater sac. And you can also get retroperitoneal hernias as well. So remember the anatomy here. So this is the peritoneal cavity right here, the interperitoneal space where your guts are. But some tissue is extraperitoneal or retroperitoneal, like the pancreas is not inside the peritoneal cavity. And part of the duodenum is not. Most of the duodenum is not inside. Only the very first maybe 5 centimeters of the duodenum is intraperitoneal. Most of the duodenum is extraperitoneal. The ascending, descending colons are extraperitoneal. The kidneys, right? The vertebrae, of course. So you can get a hernia through the posterior wall of the peritoneum. So intestines could poke out back here. Doesn't happen that often, but they could. So you get a kind of a retroperitoneal hernia there. Okay, there's my amazing drawing. All right, the foramen of Winslow, remember that? This hepatoduodenal ligament and the hepatogastric ligament together, this is the lesser omentum. And if we go beneath that, that's the lesser sac underneath that. In fact, when you're doing cholecystectomy, when you're cutting out the gallbladder, surgeons have to reach underneath this lesser sac and through the foramen of Winslow here to pinch off the cystic artery. So there's definitely a cavity here, but if there's a cavity, you can get, here's the small bowel has been removed, but you can get intestine going into the lesser sac and getting pinched in here through the foramen of Winslow. Right, and here's a cartoon of that. The intestines have went through the foramen of Winslow, and that's an internal hernia that's occurred. So that's a possibility as well. And you wouldn't be able to see that, but the patient would present with acute abdomen with all the signs of small bowel obstruction. See how that works. Some more terminology. So we have a reducible hernia. Means the hernia can be returned back to the abdominal cavity. So these would obviously be external hernias that you can see and you can poke on and push back in. An incarcerated hernia means you can't reduce the hernia. So if you had intestine sticking out your belly button, if you could push it back in, it's reducible. If you push on it and it's stuck, that's an incarcerated hernia. Very, very dangerous because that intestine is going to be dead pretty soon and it can cause septicemia and get in or cause peritonitis, which can lead to septicemia, which will kill you. Strangulated hernia. Incarcerated hernias will always become strangulated with the passage of time. And that's strangulated means they're stuck, they're incarcerated, but they start to have vascular compromise and ischemia, and they're headed toward necrosis and gangrene and big troubles. What is a Richter's hernia? So this is an important concept. I always ask this question. I don't know why I don't put more stars here. Part of the small bowel herniates, but part of it doesn't. So the entire intestine doesn't have to go through the hole. You can have part of the intestine go through the hole and still cause partial small bowel obstruction. Those are called Richter's hernia. Here's a picture of the deep inguinal ring right here. and this intestine, some of it has got sucked down the deep inguinal ring into the inguinal canal, which is not drawn here, but there would be inguinal canal around there. So this is a partial hernia, so that's called a Richter's hernia. Got it? Make sure you know that Richter's hernia is a partial hernia. And it can still strangulate. I mean, this intestine can definitely become ischemic, right? Because you got blood vessels going down here, arteries and lymph system going in here, and what's gonna happen first is the delicate veins are gonna get crushed, and you're not gonna get blood out of here. So blood is pumping in but can't get out, and that means the tissue is gonna swell, and then it's gonna cut off the arteries eventually. Once it cuts off the arteries, you're not going to be able to feed all this tissue, and it's going to die and become gangrenous, and you're going to have horrible, horrible pain here. All right, so Richter's hernias can definitely become strangulated as well. They will not cause, here's the question, will it cause a complete blockage? Is it a complete small bowel hernia? It's not complete, it's incomplete small bowel hernia, because you still can get some fecal material. The danger is with strangulation here. All right, internal hernias, inguinal hernias, femoral hernias, obturator hernias, they all have a tendency to partially herniate or become a Richter's hernia. Okay, looks like we're digging a little deeper into groin hernias. Are we going to stop here pretty soon? We got a couple more. Let's just finish up. Groin hernias, and we'll start this up again next time. So it's defined by a region that the groin is basically your inguinal ligament. It's the crack between your lower abdomen and your thigh where they come together. That's your groin. And groin hernias is a very general term which means a hernia in the groin region. Now, groin hernias are still included as a abdominal wall hernia. So umbilical wall hernias, groin hernias, spigelian hernias, they're all abdominal wall hernias. So abdominal wall hernia is the major category. Groin hernia is just a subcategory. And there's two subtypes of groin hernias. There's inguinal hernias and femoral hernias. Inguinal hernias are the most common type of hernia on the planet, and we're going to go into the weeds on them soon. They can even be subdivided into an indirect inguinal hernia and a direct inguinal hernia. Femoral hernias are more rare. They're the least common type of hernia, and I actually cut those slides out, but I do have YouTube videos on that if you want to go hunt them down. So as the name applies, these are hernias in the groin region. But this system of naming groin hernias is not universally accepted. Some surgeons consider groin hernias as an AKA for inguinal hernias. And they don't include femoral hernias in the category of groin hernias. We will include, we'll use this system that I did right here. That's our groin hernias include inguinal hernias and femoral hernias. But just know that not all surgeons believe that. They think femoral hernias are a different type. And there's a NIFUS classification system that surgeons use, and that's way beyond probably medical students and physical therapy students and chiropractic students' scope. All right. I think that is enough for today. See y'all later.